Hello, hello. Hey, what is going on? Hope you all are doing amazing. It's Dr. Delon Canterbury back again with another beautiful episode of the red pill versus the blue pill. I'm Dr. Delon Canterbury. I'm the Deprescribing Pharmacist, founder of GeriatRx, and founder of the Deprescribing Accelerator, essentially this 12-month hybrid coaching program intended to train geriatric pharmacists, prescribers, and social workers and nurses on how to implement, understand, and monetize deprescribing in their own concierge practice. So welcome back. Hope all is well. Our last episode, we were giving some advice on the history of why we created geriatrics, but more importantly, how we all can work together to combat overprescribing, prescribing cascades, polypharmacy, duplicate therapies, inappropriate medication regimens for the sake of saving our older adults. And today we're driving that point even further home. We're going to be sharing some of the 5 best practices that I have found to be completely necessary and beneficial to master in implementing deprescribing across the care continuum. And a lot of it, of course, stems from what we all do naturally as pharmacists. We educate, we teach, we educate, we motivate, and we give people hope in seeing a way out from those crazy long medication lists. I am again here today to share a little bit on what you guys might be experiencing when it comes to seeing some of these crazy intake admission notes, these medication histories and orders in 65-year-olds and up, and shed a little bit of light on what the clinical studies tell us about the prevalence of potential inappropriate medication use in some of these long-term care facilities, and also tie in the patient consult we also had today, who is in such a setting and is essentially proving the polypharmacy madness is not abating. In some ways, it gives me a job. In other ways, it's disheartening to try to understand why someone has a 20 medication long as needed list where their scheduled meds are about 24 in total. So we're talking about upwards of 40 or more meds that, luckily not all the PRN meds are used every day, but at baseline, we've got 24 scheduled and more than half of the 20 PRN that are used pretty frequently on a daily basis. So we're going to unpack a little bit of that today on how not just geriatric consultant pharmacists can have some soft wins and easy dialogues to really pose questions to get us thinking about the appropriateness and effectiveness of some of these regimens, but have us all start kind of thinking of what are some of the red flags or tools we can use to get people to hit that pain point of, are we really going to be able to stop overprescribing? And absolutely, man, I think a lot of this is baby steps in policy and just creating a team-based vision around a concerted effort and getting buy-in and just slowly changing some things to get to a point where it's streamlined across all patients. So that's my vision. That's what I hope the aging industry will advance forward in, is understanding the need for implementing pharmacists in their care management plans and in their, frankly, just in their holistic interventions in lifestyle and medicine and nutrition. And so anyway, talking about some of the facts that most of our older adults, of course, want to stay in the community. About 90% that are 65 and up reside in the community, right? About 10%, 7 to 10% live in these nursing home environments or ALFs and SNFs. So we kind of always, at least from a caregiver patient standpoint, we kind of assume if you're in a care facility, they have your best interest. They're going to have all the things taken care of. Every doctor's looking at everything. Every nurse is touching everything, every pill bottle. But oftentimes, unless you have someone advocating or doing a thorough, consistent review of things, it's not always the case. And so today was a prime example of a new intake, a new client we've got who we mentioned, again, having about 20 or more PRN meds and about 24 scheduled prescriptions. And I got the list up here with me, but ultimately, her health conditions weren't, terribly egregious. They weren't, there were maybe 3 or 4 or 5 main chronic ones. History with some mood disorders, 65 years old, but on multiple psych medications, including gabapentin and including some old school antipsychotics. So we got ziprasidone in the mix. They failed Cymbalta and they failed olanzapine after some exorbitant weight gain. And so now they're trying out another one, the ziprasidone I mentioned, which seemed to be least associated with weight gain. But, even so, you can still see weight gain within the class of antipsychotics, if it's second generation or first, whatever. Needless to say, though, the biggest issues here were preserving this woman's mobility. So when we conduct personalized action plans around deprescribing, we're using the 4Ms model. So if you haven't heard of the 4Ms model, definitely check that out. Developed by the Institute for Healthcare Improvement in partnership with, I want to say, this Catholic health system in Maryland somewhere. Drawing a blank, don't quote me, but just look up the 4Ms. It's an aging-friendly mnemonic to help health systems prepare for treating older adults. And it focuses on 4 major tenets: what matters most to the patient, what medications are, necessary, how are we preserving mobility and thus autonomy and activities of daily living, and how are we preserving mindset. So our client unfortunately had an injury to their leg. So they've been immobilized and they've been really stressing how it's made their independence or lack of power or ability to just get up and go. It's been affecting their day to day. It's been affecting their mood. And so one of our missions is, how do we make sure whatever meds this person's on isn't conflicting with their want to get up and go and do what they want to do and live their life, right? They're, 65, they're young, they got plenty to do. So those are some of the concerns, but ultimately, right, the 4Ms model is how we frame all patient conversations. And, we deal primarily with older adults. So I encourage those who have not heard of it to check out the work the 4Ms mnemonic can do for you. It's just, again, is how I like to frame conversations to make sure if we are making deprescribing recommendations that they align with the approach of what the patient wants or what the caregivers want. Okay, so that's one of the tips I recommend you guys checking out today to help streamline how you talk to people and assess their wills and wants, okay, and their passions. So what I'm finding are some of these facilities, you're just going to see all types of stuff, right? Of course, in this case, we've got tons of psych meds. We got high dose Wellbutrin, Lasix, potassium, Buspar, gabapentin, iron at a pretty high dose. We got 2 forms of levothyroxine, B12 shot, gabapentin, nystatin, Depakote with no seizure history, but there is a history of bipolar, so they are using it for manic episodes of bipolar. She hasn't been manic lately, but she still finds herself using a good bit of PRN anti-anxiety meds. Also on some trazodone. She's still on Geodon or ziprasidone 60 twice a day. They've also added Prestique 100. Also has an autoimmune disorder, common variable immunodeficiency disorder, something I had to look up and learn. Or CVID is what another way it's designated, but it essentially, she doesn't have the strongest immune system. So that's something to keep in mind. And so thus there are chronic UTIs, which she is also using D-mannose, some pomegranate juice, or cranberry juice, to help with managing those issues. All right. Along with an infusion once weekly to Hizentra for the CVID. We also got fentanyl. Fentanyl patch. I mean, okay. But yeah, she's been on fentanyl. And when I asked her, generally what's your pain like on a day-to-day basis, she's still at a 6 out of 10 on the pain scale. And she uses an estradiol, looks like cream, 2 times weekly. So still has pretty significant pain. Luckily, this was one of the few patients who actually had a genetic testing report. So we talked about how, the 4Ms is how I like to, kick off my Deprescribing convos. The next thing is kind of an obvious one, but it's like, hey, are they on more than 5? Of course, they're usually on more than 5. We know 5 is the sweet number. Designated that more than 5 is considered as polypharmacy. And the more polypharmacy, we know the higher the potential risk of harm or drug interactions. And in some studies in the ultra old, we have seen the addition of one medicine for those with hyperpolypharmacy, more than 10, can increase mortality by about 3% with each addition. This is a European study, which I can happily cite for you guys. So polypharmacy, we know, is a big no-no. And here we've got 20 scheduled, 24 PRN. We've got some significant issues we got to address, right? So you would think, oh, I'm in great pain management. My pain is fine. Like, no, she's on fentanyl, 37.5, still a 6 out of 10 out of pain. She uses Tylenol 3 for breakthrough pain. Okay, so clearly she's hitting the polypharmacy, hyperpolypharmacy definition. So now one of the third best practices I like to use, apart from, of course, 4Ms and, of course, HE on more than 5, is truly looking and seeing through each med, is each and every one vital and important for them to live? Like, is it absolutely vital for you to live with this, or is it important for your quality of life? Okay, so that's now the next wave of tools in my tool belt is how do I meticulously review all these meds to see if that's truly necessary? And here we had quite a bit of prescribing cascades. What do you know? It's all over. Multiple anticholinergic medications. We actually discovered today that she has not had a bowel movement in quite some time, and she's usually has it regularly once a day. But in the last week or two, she has had some pretty severe constipation. And yes, she does have a fairly high anticholinergic burden with some of the meds she's on. If you don't know, Lasix actually it does have a small contribution to anticholinergic burden. I think it scores a 1 on the anticholinergic burden scale, which we know if it's 3 or more, there may be some high risk of cognitive impairment. Now here we don't really have any, signs of dementia, but we do have mental health history of bipolar irritability cognitive. But eventually, we want to look at all these meds and really see, does she need iron 325, which is scheduled every day? Have we assessed what her recent iron labs may be, or how is her blood work looking? Does she have problems with hemoglobin or whatever? And constipation is highly associated with an iron tablet, which she's taken orally. So this is, again, it's kind of asking these questions to work your way backwards to, all right, so if we know that these are most associated with constipation, if we were to stop it, what would happen if we did? And do her numbers still look good as we're deprescribing? Which is why I believe labs are super important throughout the process of deprescribing, not just as a one-time and let's see what happens next. So that's one of the first things I'm like, do we truly need ferrous sulfate 325 at this moment? Additionally, I'm trying to see what else might be anticholinergic. A little bit of trazodone in there. We got a little bit of ziprasidone on there. Prestige, I actually haven't checked for that yet. Fentanyl, opioids do have some mild anticholinergic activity. A lot of her PRN meds are extremely anticholinergic and thus may contribute to constipation. So as she has been going through PT and OT recently, she's been going through these forms of therapy, she's had a lot of pain from the breakthrough of going through therapy. So she's been using a lot of methocarbamol, Robaxin. She's been using more Flexeril, cyclobenzaprine, and she's also been using Benadryl for like her allergies a bit more lately. And then she also uses an additional dose of Trazodone 150 to help with sleeping. So all this being said, there's been increased use because of the increased start of therapy, and thus, this pain is giving her all these now 2 different muscle relaxers, right? Chronic, a lot of Tylenol 3, all right? She also has Percocet, Xanax, and just Tylenol. Just Tylenol, liquid for breakthrough, but she finds herself using Tylenol 3 the most. So if you can't imagine, that's a lot of anticholinergic burden right there. And with the increased use of those meds in the last month or two, she has found, more constipation. So now, again, this is what pharmacists are good at, and especially those who become deprescribing advocates. We're good at working backwards and seeing what the causative issues are, or at least suspected causative issues are. And here we got a ton of muscle relaxers contributing. So another third tip, man, if you're over 65, you may as well check that anticholinergic burden calculator. So maybe that's tip number 4 I gave you. We talked about the 4Ms approach. We talked about being on more than 5 or 10 medications. We talked about assessing to see if the medications are absolutely vital and important for the patient to live, especially at this time in their life, not when they were 30 or 40. And now, I guess the 4th tip I'll say straight up is check that anticholinergic burden scale. Check the anticholinergic burden scale. Check it in dementia. Check it for everybody over 65 and see what's going on, especially with the most recent use of her increased anticholinergic PRN meds, as needed meds. So she's mentioned she's using a lot of them, and she hasn't had a bowel movement in almost over a week, is what she said today. So that is a clue for us to assess her fiber, assess her diet, assess her water intake, all the holistic things we can try to rule out first if there's any changes. And mind you, she is an LTC. Unfortunately, guys, they do not have, buffet. It's not the best food. All right. Just straight up, you're not going to always get the most nutritious, wonderful, healthiest meals there. So she is finding herself having to DoorDash healthier food options to meet some of these nutritional goals, as she's also dealing with a little bit of obesity in her care. So, ways to holistically treat without jumping to, you need now Senecot and, magnesium citrate or something. You won't have to jump to the shotgun when we could probably slowly address this. But needless to say, she needs to go now. So that's room for improvement to discuss deprescribing opportunities. So you guys may be wondering, right? Man, there's all these meds, there's all these issues that we can see. Like, how would I truly know how to do this and act on this if I'm not a clinician, or if I'm a part of a care management group or a nurse, and I don't feel like I know all this stuff? And I'm saying you don't have to quite know all the intricacies, but you got to know how to advocate and feel comfortable to start asking the tough questions on, is this really holistically doing what's best for our older adult? And that's why I frame these convos like, are they my grandma? Is this what I would want if this was my grandma, in front of me? And that's how I try to treat every patient. So you may feel like there's a lack of guidance. You may feel like, it's not, your job, or it's not a part of your license or training to advocate for less harmful med use. You may feel like there isn't a system in place, right? You may not feel like you have the oversight, right, to even do this. Like, do I even have the autonomy or authority to do this? You don't see a possibility that there can be less meds, because the systems makes us think you got to be on all this stuff all the time. And you don't have to take everything on that order set, ladies and gents. I mean, I'm not here to tell everything needs to be shut down and it needs to be zero, but we do need to question if someone truly needs to be on 20 scheduled meds and 24 as needed meds. Like, I think that's kind of a big deal. And so that's what our program is intended to provide you guys with, is a system, a toolkit, a process flow to deprescribe or to advocate and kickstart healthy conversations with the prescribers, and to help bridge some of these gaps in care. As you know, we have specialists with different disease states and different areas of focus, and of course areas of priorities. But at the end of the day, a lot of these reports I get are from geriatric care managers, and they never really, they knew something was wrong, but they didn't know what to do. And that, my friends, is why we need deprescribing advocates, concierge pharmacists, consultant pharmacists who do this day in, day out, who now have a chance to put it tenfold in its impact and really work with people step by step, week by week, to taper slowly and systematically with your doctor's supervision on how to minimize the harm here and really improve quality of life. That's really the ultimate win, is making our patients feel better and showing that they feel better, would hopefully be the need for less meds. So for those who are feeling frustrated with this burden, you're not alone. You're not alone. The solution are like-minded people who think holistically in healing, who are open to lifestyle medicine, who are open to functional approaches, who are open to doing everything non-pharm as much as possible, unless it's absolutely needed. And if it is needed, we're going to always question what the timeline is. All right. We're going to always question what the timeline is. And so as we're making our recommendations and building up our action plan that we're going to present to the providers, we want to, of course, keep the patient's needs in mind. And so when we used the 4M's approach, the patient was most concerned about being able to walk and do what they want to do at their own time without feeling stuck in a chair. And they wanted to live long enough to see their grandbaby born. Okay. They wanted to live long enough to see their grandbaby born. So all these med stuff I could talk about all day, but they care about seeing their grandbaby the most. So when you're able to tie in what we're doing to, in a way, reduce potential harm that may lead to a fall, like we mentioned, we got multiple anticholinergic drugs, we've got maybe some dehydration. We also got, fentanyl use along with other opioids. And she's afraid of them. She doesn't want to be on them. And she's worried about being on them for 5, 10 more years as she starts hitting 70 and 80. And she has a legit concern. So my mission is, let's get your pain better managed without them, in a way that's amenable to how you want to heal, so that you can see your grandbabies, right? So that you can live long enough to see your family. And that's how you get the buy-in, right? That's how you get the initial deprescribing, I guess, just care. So it's personalized to the results tied to our action as a deprescriber. So that's really why I have to hone that in. And this is probably the 5th best practice, is if you're not leading with empathy, my friends, what are we doing this for? If you're not even relating to where the person's at, then you're just talking at them. And so there is no deprescribing action plan if you're not building this rapport or this sense of camaraderie of, we could do this together, right? Or, this is going to take some time, but I got you. I'm going to advocate for you. So empathy, man. That's straight up just what it has to be in order for healthcare to truly, truly, truly work. And I mean substantially work in a way where we can see the results time and time again. So that is where the personal piece of this comes in, is you can do the best damn med review on earth and figure out everything wrong and come up with all the answers. But if you're not doing it in a way that's with shared decision from the patient and caregiver, or in line with their overall mission, which in this case is reading more and walking more and seeing their grandbaby, then what's the point of all of this, So I want to really shed that light. But this is why I believe the necessity for us to employ and use consultant, concierge, holistic pharmacists in these care settings can make your aging care practice just blow up. It will just explode, because this level of touch point, this level of understanding, this level of education, this level of motivation, and just insight that we innately have as clinicians is what's missing in aging. And we can do better. And so who better than consultant pharmacists and geriatric nurses and geriatric PAs and NPs and geriatric focused social workers who are in these settings, and they see the med lists that are 15, 20, 30 lists long, yet they don't know how to start the conversation other than, well, talk to your doctor and let's see what happens. Like, let's build some more ammo with these deprescribing cases and show the evidence of harm. And let's do it in a way that's gradual. We don't have to just slam dunk deprescribe, take everything off. It doesn't have to be that extreme. It could be one or two here, piecemeal, gradual. You monitor, you continuously follow up, you educate, you make sure nothing has led to any harm or withdrawal symptoms. And then you educate on such risks, and you just have a candid conversation on the pros and cons of keeping something on or taking something off as best as you can, and do it in a way that's, well, gradual. So we know if we do stop something that it actually was that agent. So again, I think I made a number of best practices, but at least the last one was more driving home the importance of empathy and doing it in a way that's patient-led. But anyway, there were quite a number of issues. This was more of a scoping overview. We didn't do the full comprehensive deprescribing thing yet. We're going to do that going forward. But today was more of like ground setting, like, what's up with the patient? What do you want? Where do things stand, like your pain or your day-to-day? Like, what's your daily life right? And unfortunately, she's chronically using the restroom. So much so that she feels she has to hold it in. And unfortunately, the facility she's at, she feels like they don't pay enough attention to change her frequently. And so she complains of having a lot of chronic UTIs and finds that people are hesitant to want to change her because, she may be a little bigger. But that's at least the sentiment she has shared. So now she feels embarrassed, and now she feels her independence and autonomy is just gone, and she's embarrassed to ask for help. So it's crazy how, and this is where one of the care managers asked, well, no, we can't control that. And I was like, no, actually, we can control that quality of life piece. Like, if this furosemide, which is furosemide 40, is causing her to urinate so much that she's now having, increased UTIs and now, more bedwetting and constant changing, that there's a downstream cost of time, energy, and resources that may affect the facility or the nurse. But of course, in my world, it's the patient and their quality of life and happiness. And so if it's screwing all those things up, having a pharmacist intervene to say, let's switch to furosemide or half the dose or try another medicine to manage the blood pressure, we can save a lot of those downstream costs of energy and time wasted from just one simple intervention. Like, this is where deprescribing, med optimization, whatever fancy words you want to use, ultimately, we're doing all we can to minimize unnecessary pills in their drug list. And that's, an easy win I can advocate for this patient case. And mind you, her blood pressures are completely normal. Her blood pressures are like less than 120 over 80, constantly less than 120 over 80. We're talking hundreds and over 60. So to me, it's actually a little too low. But, we fight these battles as they come, right? Now, in this case, we had pain as an issue. We had over diuresing. We clearly have bipolar past a couple number of decades. And so there are quite a bit of psych meds in here that are going to be, there's going to take some, it's going to take some delicacy to slowly and gradually wean off over months to years. I mean, she's pretty much on 5 or 6 different psychoactive agents. I mentioned again, ziprasidone, Pristique. She failed, trazodone, Depakote. She's on gabapentin for pain, but it's still psychoactive. And she's on Wellbutrin 300. And she's on Requip 2 milligrams twice a day, which is a dopamine agonist more targeted to restless leg syndrome, but it could still have a dopamine antagonistic effect. So there may be still some type of neuro effect from that. So a lot of these things, I'm going to have to really ensure that the genetic testing report takes place. And so maybe a bonus tip is if you're working with psych meds or psych patients or pain meds, get a genetic test. It is one of the best tools I've used to advocate for Deprescribing. If the facility can write it or bill for it, do that. If they got Medicaid or Medicare, depending on their state laws, they can fill it that way. It is covered. There may be a copay. Original Medicare, there isn't a copay, or they can just order the test themselves, pay cash, and get their own results. But part of what we unearthed today with this review is just to ask for that genetic test. Thank God this patient already had it from a couple years back. We found that they were CYP2D6 intermediate. So certain medications, hydrocodone, codeine, there's some others, warfarin, just may not do as well for people who have an intermediate genetic disposition for that. So we were able to find that she was eating Tylenol 3s like candy, and it makes sense. The Tylenol 3 that she takes does not get converted as well to the active form to have pain resolution. And so because of that genetic test report, which is so helpful, I can see why her pain management wasn't being adequately handled. So again, critical use there. It also has a lot of versatility. Hey, brother, hope you're doing well, man. Good to see you. It also has a lot of versatility when it comes to psych issues, psych concerns, and bipolar. So like she was on 4 or 5 different psychoactive agents. Luckily, a lot of the ones on her list weren't like genetically affected or they're considered to be minimal gene-drug interactions. But, there's some things going on that we want to dig into, and I haven't fully done that yet to cross-check all the meds with her genes. But for the most part, at least the psych meds to me look clear, but some meds interact with others. And so when it's another medication may interact with the other, it may physically act as if there is a genetic deficiency. That's a nuance. That's a little bit in the weeds. My point is, if you suspect or see a lot of people failing medicine regimens, or if you see people with psych issues or cancers or pain management, advocate for a genetic test if they haven't had it yet. Advocate for it. Ask if their providers can order it for you. If not, ask your local concierge, consultant pharmacist, or geriatric genetic counselor to order one for them, see if it might be clinically helpful. And I find it to be oftentimes very helpful in painting some of the pictures on why people may fail certain medication classes. So, needless to say, mouthful of advice and education today, but I hope it was helpful. We covered a lot, from personalizing your care, leading with empathy. Are they on more than 5 or 10 medications? Asking that question. Discerning the lifetime importance and lifetime benefit of a medicine, right? Talking through if this is extremely vital or important for me to live. Super important. Advocating for genetic testing as a bonus best practice for people. For pretty much anyone. I mean, it is more affordable now. So I always recommend it if you can get it, regardless of you taking meds or not. It could potentially save your life down the road based on better medication choices, okay? So my point is, guys, whether you're a caregiver, whether you're a prescriber, whether you are a physical therapist, whether you're a concierge pharmacist, or trying to roll out your own deprescribing service, we ain't got enough people doing this, all right? We don't have enough, straight up. And if your business is able to position itself in working with us or other consultant pharmacists in a way that personalizes that need in perpetuity, not just as a one-time thing, right? This is going to be a whole game-changing service, and it is already a game-changing service from what I have done myself. So I know this could be done for other businesses. So don't just keep sitting on these long med lists and wondering, what do I do next? Ask these questions we've posed today. Talk to your local pharmacist, talk to your geriatric pharmacist, talk to a Deprescriber, talk to someone who understands, how to unearth this maze of meds, and let's fight back together against overprescribing. All right. So hope this was helpful. You got to get your own concierge pharmacist, guys. Your businesses, your aging businesses, if you're providing care, you got to have someone on your team. I mean, in just 2 reviews, we've been able to find what are obvious to us, which were ongoing issues for some. And it's been a cost barrier for people when it all could have been prevented had someone looked a bit more thoroughly for deprescribing opportunities. Okay. So hope this works. And then I'll give you another bonus. If your patient is just overall not happy with their quality of life and they're 70, 75, and they just feel like they're wasting away, then hey, probably some of these meds ain't helping. Let's take a thorough look at whether it's necessary now. And I even talk about the other slew of meds this woman has, like omeprazole, like potassium, just because she's on the water pill, folic acid, I'm not sure. She's on B12, she's on nystatin. And also estradiol. So I don't know if it's a tablet form or I think it's a cream, but my point is, question everything, man. Question everything, and use your deprescribing advocate or pharmacist to make the job happen for all of our older ones. Okay. So much love. We'll see y'all next time. Let's learn how to unpack this burden of overprescribing and do it together. All right. Y'all take care. Much love. Thanks for tuning in to the Red Pill versus the Blue Pill.